is the is about the beta blockers. So historical background wise, let us look at the when it was invented in 1948. Breakthrough in understanding the autonomic nervous system when Alquist demonstrated two forms of catecholamine receptor, that is alpha and beta. In 1962, Black demonstrated the first therapeutic beta blocker, that is propranolol. And then beta blockers are further classified to beta 1 and beta 2 receptors. Beta blockers were first developed by Sir James Black and the Imperial Chemical Industries in the United Kingdom in 1962. They are considered one of the most important contributions to clinical medicine and pharmacology in the 20th century. Sir James Black was awarded the Nobel Prize in 1988 for the advances in medicine. So this is a list of beta blockers that is approved by the United States over the years, that is probably over the last 5 to 6 decades. So as we can see, in 1967, propranolol was the first one that was invented, and eventually metoprolol tartrate, which is a short-acting form of the metoprolol that we all know, and then eventually atenolol, pindolol, and temolol, and sotalol, and metoprolol succinate, which was invented in 1992. Similarly, bisoprolol was also invented in 1992, and propranolol XL, and then nebivolol in 2007. So the problem is that how there are so many of these various drugs. Some of them, like labetalol, have very, very specific indications, or sotalol, which have antiarrhythmic indications. But many of them are have many multiple common indications, and so we are here to see which ones are better. So the beta blockers in heart failure, this is a slow introduction, but in 1975, there was the first report which was launched by Vaxtine et al. In 1979, the indication for improved survival was noted by Swedberg. And in 1993 to 1999, it was confirmed in large-scale clinical trials that carvedilol, bisoprolol, and metoprolol have definite benefit in terms of survival and in terms of reducing the cardiovascular mortality in patients with heart failure. So beta blockers are not a homogeneous group of agents. They have they differ in their potency and duration of action. They differ in their cardioselectivity in terms of beta 1 and beta 2 blockade. Some have intrinsic sympathomimetic activity, and most don't. Lipid solubility also is a major factor as far as their duration of action goes. So the main factors contributing to the heterogeneity are, as we have noted, within the beta blocker class is beta 1, beta 2 selectivity, vasodilation properties, then the efficacy, the metabolic profile, and the side effects of each drug. So as we can see here, beta 1 selectivity is our concern as far as almost as long as we are looking for the cardiac perspective and for heart failure objective. And as we can see here, the propranolol, which is almost neutral and has no specific selectivity towards beta 1 beta 2. On the other hand, metoprolol has 1:20 beta 1 selectivity, atenolol slightly more at 1:35, betoxol a little more, and as we can see here, bisoprolol has significantly more beta 1 selectivity as compared to the commonly used metoprolol and atenolol. So, bisoprolol, beta blocker is a practical view. As we can see, not all beta blockers are created equal. Carvedilol, metoprolol, succinate, and bisoprolol. That is, carvedilol has beta 1, beta 2 at 1:1 ratio plus an alpha 1 activity. Dosing is normally BID, and the cost is again significant. Metoprolol succinate has 30:1 beta 1 to beta 2, but again, depending on what molecule we use, or sometimes we even prefer giving BID dosing. Bisoprolol again has a significantly more selective beta 1 activity with 1:30:1 ratio. The dosing being only once, as it has a half-life of almost 12 to 14 hours. And the cost again is relatively quite low, as it was invented long back, and there are multiple brands available, and most of the companies have managed to keep them at a very low pricing. More than 3 times the cardioselectivity of other beta blockers, and 3.4-fold greater than that of atenolol, and 3.3-fold greater than that of metoprolol has been noted. So as we can see here, the comparison chart of beta-1 selective blockers. So these are the most commonly used. Let us look at the first three. The ace-butalol and celiprolol are not that common, but bisoprolol, atenolol, and metoprolol are the most commonly used drugs. And as we know here, that plasma half-life for bisoprolol is 10 to 12 hours. For atenolol is 6 to 9. For metoprolol is even shorter than that at 3 to 4 hours. The absorption percentage is more than 90% for bisoprolol, more than 95% for metoprolol. The first pass effect is not there for bisoprolol, whereas it is present for metoprolol. And bioavailability is at 88%, which is significantly better than the other two. The protein binding is also better than the other two. And this is already an active metabolite, so it doesn't need any conversion. And balance clearance is also present with partly by the liver and partly by the kidneys. Now, what we need to know here is that normally T half of 4 to 5 cycles is required for clearance of the drug, and if 3 to 4 cycles are required, then then 3 to 4 cycles are required. Then normally within 12 to 16 hours, 16 to 20 hours, the entire dose would be cleared from the body, and there would be no effect, and that would lead to a drop in the effect of the drug. On the other hand, as we can see here, bisoprolol has a 10 to 12 hours, and so the clearance of the entire drug from the body would take more than 24 hours, and hence it is definitely better in terms of the T half-life as compared to atenolol and metoprolol. Here we can see the comparison to non-selective beta blockers, and sometimes non-selective beta blockers are also very commonly used. Propranolol, especially for isolated tachycardia, and carvedilol, especially in heart failure. And as we can see, carvedilol has 7 hours of half-life, and hence BD dosing becomes very compulsory. Propranolol also the same with 3 to 4 hours and a very short duration of plasma half-life, and that is why many a times we see propranolol which is given maybe 2 or 3 or 4 times a day. Absorption percentage is again more than 90%, bioavailability at 88% versus only 25% for carvedilol. The active metabolites are again the same as I mentioned before, and balance clearance is present only for bisoprolol as compared to propranolol or carvedilol. So the overview of the pharmacokinetics of bisoprolol are that absorption is more than 90%, bioavailability is approximately 90%, plasma binding, plasma protein binding is at 30%, and metabolism is 50% from liver and 50 from the kidney, and plasma elimination half-life of almost 10 to 12 hours. So bisoprolol has a balanced clearance, as I mentioned before. What that means is 50% renal elimination of an unchanged drug and 50% hepatic metabolism to an inactive metabolite, also renally excreted. Metabolism only by oxidation and no subsequent conjugation. There is primarily by CYP3A4, that is 95% approximately. Only minor contribution to CYP2D6, and that is metabolism not dependent on this gene polymorphism. So we need not worry about that. So no dose adjustment necessary in mild to moderate liver or kidney impairment. No dose to be limited to 10 milligrams in daily dose to be limited to 10 milligrams in severe liver or kidney impairment. Now this is another major concern while starting beta blockers, especially in the young or the middle-aged population. It often leads to erectile dysfunction and male sexual function is declined. Bisoprolol, on the other hand, is an ultra beta 1 selective drug and hence has minimal effect on the male's sexual function. As we can see, as compared to placebo, enalapril, and amlodipine, we don't even think about many times of giving enalapril and amlodipine to a patient, male patient, and it having an effect on his sexual function. And whereas bisoprolol is even less as compared to amlodipine. So let us look at the route of elimination now. So various drugs have been listed here with atenolol and sotalol on the complete right-hand side, which has 100% of renal elimination, and propranolol, metoprolol, or nebivolol, or carvedilol, which has 100% liver elimination. Bisoprolol, as I mentioned before, has excellent effect because of its 50% elimination through liver and 50% through kidneys. Beta blockers dialyzability in chronic hemodialysis patients is also fairly good as compared to carvedilol. So carvedilol is one of the most commonly used beta blockers in heart failure. And so if you compare it to bisoprolol, carvedilol is very poorly dialyzed as compared to bisoprolol. So let us look at the product information. This is a very practical outlook. So mild to moderate impairment, no dosage adjustment is normally required. So severe renal impairment, that is creatinine clearance of less than 20 ml per minute, maximum daily dose of 10 mg bisoprolol. So in a normal individual, the maximum dose that is tolerated by a patient would be around is for hypertension especially is 20 milligrams, although we do not start at that maximum of a dose, and this also depends on the patient's heart rate. So in kidney dialysis, experience with the use of bisoprolol in renal dialysis patients is limited. However, there is no evidence that the dosage regimen needs to be altered. Hepatic and liver impairment, mild to moderate impairment, no change required, whereas in severe hepatic impairment, maximum dosage is 10 milligrams of bisoprolol per day. So, to summarize, beta 1 receptor selective, there is no adverse effects on lipid metabolism, no adverse effects on glucose metabolism, better than atenolol, as good as newer drugs, better 24 hours coverage, then sustained BP control over long term, and no sudden changes during exercise. Bisoprolol is a preferred beta blocker for the treatment of heart failure, angina, and hypertension under MMP guidance. So let us look at the extensive cardioprotection capabilities of beta blockers. The beta blockers can slow or interrupt the progression at many points along cardiovascular continuum, thus providing extensive cardioprotection. So one of the major problems with beta blockade and with the myocardial heart failure or is neurohormonal activation. And so beta blockers is the first line of drug that we normally prescribe in heart failure or non-decompensated, as in like patients who are stabilized and not in acute failure. Beta blocker is the first line of therapy that we normally start. So it has beta blockade also has an impact on the remodeling, ventricular enlargement, and chronic heart failure. It also has an impact on the angina and its prevention in terms of atherosclerotic coronary artery disease. And so risk factors like hyperlipidemia, hypertension, diabetes, and smoking are also partially controlled. And so it is a multifactorial thing which eventually leads to lesser loss of life. So, whom do we give bisoprolol for? Is heart failure an only line of treatment for bisoprolol, or can we give it in other patients also? So the answer is, I think there are a lot of indications where bisoprolol can be used. Apart from heart failure, hypertension itself, post myocardial infarction, hypertension plus coronary artery disease, hypertension plus elevated heart rate, and these are very good examples of where bisoprolol can be commonly used with excellent results. So bisoprolol, the most cardioselective beta blocker. So this study was published in the British Medical Journal, and efficacy and tolerability of beta 1 selective beta blockers bisoprolol as a first-line antihypertensive in Indian patients diagnosed with essential hypertension. An open-label multicentric observational study was done. So the article focus was what is the efficacy of bisoprolol in essential hypertension patients, and what is the average dose of bisoprolol required for BP control, and also what is the tolerability of bisoprolol in essential hypertension patients. The key messages that were delivered were: bisoprolol is safe and effective in stage 1 essential hypertensive patients in India. The average dose required was at least 5 milligrams per day, and the target BP achieved was noted in 96.4% of the patients. So evidence-based use of beta blockers, as we can see here, an acute myocardial infarction has multiple impacts on the heart. It's not just the LV systolic dysfunction that is in the long run, but also, as you can see, there is concentric LVH and multiple other factors which lead to myocardial functional decline. And in both those scenarios, beta blockers in the long term help. So evidence-based doses of beta blockers, as we can see here, bisoprolol can be started at a very, very low dose of 1.25 milligrams OD, and then targeted to a dose of 10 milligrams OD, depending on the heart rate of the patient. Carvedilol, being less beta selective, requires 3.125 BID dosing and is a target dose that is recommended by all the clinical trials is 25 milligrams BID. Metoprolol succinate of 12.5 to 25 milligrams OD is the dosing that is starting dose normally we do, and all the big clinical trials have recommended a dose of 200 milligrams OD. Nebivolol again 1.25 and then OD dosing and target dose of 10 milligrams OD is recommended. Double dose every 2 weeks if tolerated is the recommended plan, and after of course watching the heart rate and individualizing the patient's treatment protocol. So as we can see at the bottom, they have given a chart where week 1, 2, 3, 4, 5, and then 4 to 7, 8 to 11, and 12. And bisoprolol will be started at 1.25, week 2 again 2.5 upgrade, week 3 again add 1.25 to 3.75. Eventually, after a month, we somewhere in the second month we try and upgrade to 5 milligrams of OD. 8 to 11 weeks at 7.5, and then eventually at 12 weeks to 10 milligrams OD. Now, this depends on the blood pressure of the patients and the heart rate of the patients. If the patient's heart rate and blood pressure can sustain it, we can even see a more aggressive pattern of increasing the doses. So, block sympathetic nervous system by beta blockers is also another important aspect. So, bisoprolol at 1.25 mg daily or 10 mg daily, and versus carvedilol, which is 3.125 BID, that is a lot more pill burden on the patient with 25 mg BID at the end of the for target dose. So, as we can see here, which is noted in Canada, people hold off titration until the fluid status is stable. They may experience slight increase in fluid retention within the first 2 weeks following up titration, and which we normally manage by diuretics even in India. If people have low BP, prefer bisoprolol, and because it is more beta selective, we normally stagger the timing, if especially if it is to be given with ACE inhibitors or ARB, as in giving ACE inhibitors in the morning and giving beta blocker in the night, or at least 2 hour difference between the timing. Taking with meals slows the absorption. We advise taking in the evening rather than in the morning doses, and consider decreasing the diuretic because water retention is not as much as with some other drugs. So the tips for optimizing medications, especially with patients who have low blood pressure. As I said before, we have to stagger the dose ACE inhibitors and ARBs because they are potent antihypertensives and beta blockers. At least 2 hour difference between the medications. Then consider splitting the daily dose of to BID in case the patient is still unable to sustain a moderate dose of the beta blocker. Start with low doses and increase slowly to help reduce side effects monthly versus every 2 weeks. As we mentioned before, increase in 2 weekly doses. Instead of that, we can go to even increasing the dose frequency to 1 month. When trying to titrate ACE inhibitors, ARBs, or beta blockers, consider only increasing the PM dose. If tolerated, then increase the AM dose at the next visit. Use bisoprolol rather than carvedilol, which is more beta-1 selective and hence will have slightly lesser effect on in terms of hypotension. Give beta blockers with meals, that is slow absorption. Consider decreasing the diuretic dose because many a times the patient comes to our OPD with frank failure or frank chronic failure, and we give high doses of diuretics. Over the next 1 or 2 weeks, the patient's fluid overload is reduced significantly, and we tend not to reduce the diuretic dose, and patient lands up with either in prerenal or patient lands up with hypovolemia leading to further low BP. Consider volume depletion. That is, again, as I said before, excess diuretics is quite a common cause for volume depletion, or other medications for the cardiovascular or other systems that can contribute to hypotension or orthostatic hypotension, such as especially alpha blockers. So heart failure, is there a class effect by beta blockers? So yes, there is some amount, and some of the newer ones such as bisoprolol, metoprolol, succinate, and carvedilol have been studied extensively with trials such as the CIBIS-2, the MERIT-HF, and the Copernicus trial, and all have shown a definite benefit in terms of reduction in annual mortality, risk reduction for all three drugs. So as we can see here, the carvedilol versus the placebo class, there is a risk reduction of 65%. CIBIS-2 shows bisoprolol versus placebo with risk reduction of 34%. Copernicus with again carvedilol and risk reduction of 35%, and Merit HF with metoprolol versus with placebo with a risk reduction of 34%. So we cannot directly compare these trials to each other because they are done in different formats and with different drugs. No, so we cannot compare 65 to 34 because these are different drugs. The inclusion exclusion criteria were different, and there is no head-to-head comparison between bisoprolol and carvedilol in that fashion for risk reduction. But yes, what we are talking about here is a class action as far as beta 1 selective beta blockers go. So as we can see, selected trials of beta blockers here. So the carvedilol trial or the Copernicus trial, Merit HF, CBS2. As we can see, the mortality reduction has been significant with 65%, 35%, and 34% with bisoprolol. 95% clearance can also be seen with of the drugs with CBS2 at 19 to 47%. So what is statistically significant is this class of drugs, which is basically the newer more beta 1 selective drugs, are statistically significant versus the bucindolol, which is not so selective. And mean duration of months of follow-up for each trial was significantly long, with the bisoprolol trial going on for almost 15 months. That's almost 1 year and quarter. So the cardiac insufficiency bisoprolol study, CIBIS, studied bisoprolol, a highly selective antagonist of beta 1 adrenal receptors, which are found mainly in the heart and especially in ventricular tissue. That trial showed a non-significant trend towards 20% lower mortality in the bisoprolol group and 30% fewer admissions to hospital for worsening heart failure. So as we can see here, bisoprolol versus placebo, 23 months, primary endpoint being death. Result was 20% reduction in the death, and in CIBIS-2 even further reduction at 16 months with 34% reduction in the primary endpoint. The cardiac insufficiency bisoprolol study, that is CIBIS-3 trial, has been presented at the European Society of Cardiology hotline session 2000. And the primary endpoint was combination of all-cause mortality and all-cause hospitalization at study end. So the CIBIS-3 trial studied almost 1,010 patients more than 65 years with mild to moderate chronic heart failure, that is class 2 or class 3, with LV dysfunction less than 35% EF in 3 months prior to randomization, clinically stable CHF for at least 7 days. So the divided into two groups. That is monotherapy with beta blockers, bisoprolol for first 6 months, 10 milligrams OD. Then monotherapy with ACE inhibitor, enalapril, first 6 months, 10 milligrams BID. Combination with ACE inhibitor therapy, 24 months. Then primary endpoint, time to the first event of combined all-cause mortality and all-cause hospitalization throughout the study. Secondary endpoint was combined primary endpoint at the end of monotherapy phase, individual components of primary endpoint at study and then end of monotherapy phase. Basically, this is a trial between monotherapy of beta blockers versus monotherapy of with ACE inhibitors. So in CIBIS, the 3 was the first such trial to compare the effects of beta blockers first strategy with that of ACE inhibitors, first on the hard endpoints of mortality and hospitalization. It showed that bisoprolol first and enalapril first groups were comparable with regards to the primary endpoint, all-cause mortality or hospitalization, and all secondary endpoints. Moreover, bisoprolol first showed a trend towards improved early survival. This suggests that during early treatment of chronic heart failure, Before combination therapy can be initiated, a beta blocker first strategy might be predicted to improve survival, allowing a greater number of patients to subsequently benefit from the combined beta blockade and ACE inhibition effect, as well as the other drugs and interventions. So the CBIS 3 sorry, the CBIS 3 summary is that the cardiac insufficiency of bisoprolol examined the optimum order of initiating CHF treatment in almost 1,000 patients above 65 years with stable, mildly or moderately symptomatic systolic heart failure. Patients were randomized to initial monotherapy with bisoprolol for 6 months and followed up by addition of enalapril or the opposite sequence. Mean follow-up was almost 1.2 years. The bisoprolol first and enalapril first strategy showed similar efficacy for the combined primary endpoint of mortality and all-cause hospitalization and similar safety. Compared with the enalapril first strategy, the bisoprolol first strategy significantly reduced sudden death during the first year on treatment by 46%. Patients who achieved higher doses of the study drugs, particularly bisoprolol, had substantially and independently lower mortality and hospitalization risk. Thus, CIVIS 3 supports a free choice between bisoprolol and enalapril as initial therapy for stable, mild to moderate systolic CHF and suggests that early beta blockade reduces the risk of sudden death in the first year. Carvedilol versus bisoprolol, the Japanese experience, hypertension and bradycardia was noted more with carvedilol. Severe NYHA class 4 patients were again seen more with carvedilol. On the other hand, it was noted that bisoprolol was used more with tachycardia and atrial fibrillation. And normal to hypertension patients, bisoprolol was the drug of choice. With COPD also, beta blocker required, bisoprolol was the drug of choice. Bisoprolol is the preferred beta blocker for the treatment heart failure, angina, hypertension under MA guidance. Bisoprolol is licensed for hypertension, heart failure, and angina. Bisoprolol has once daily dosing for all indications. Many strengths are available all the way from 1.25 to 10 milligrams. Dosing and titration of bisoprolol is the same for angina and hypertension. And bisoprolol has a favorable clinical outcome data and has a favorable side effect profile as well. Thank you.
Thank you, sir. If anyone has any questions, you can ask in the chat box, or you can even ask by raising your hand or unmuting yourself.
Yes, so if somebody has asked a question saying switching protocol from atenolol to bisoprolol, can we use bisoprolol in thyrotoxicosis patients instead of propranolol? I would not recommend that because I mean bisoprolol is not been studied for thyrotoxicosis and it is not hyper for only for tachyarrhythmia or for tachycardia, whereas propranolol will have a much better impact in terms of controlling the tachycardia that is noted with thyrotoxicosis. Yes, the multiple side effects that bisoprolol has due to beta-1 selectivity on the cardiac remodeling and the heart is the reason for it is recommended as it why it is recommended in heart failure. So to answer your question, no, I would still prefer giving propranolol for thyrotoxicosis patients rather than bisoprolol. And as far as switching protocol from atenolol to bisoprolol, I would not. Just as normal switching from atenolol to bisoprolol, I don't think there is any special protocol here. Since both drugs are from the same group, I don't think any washout period is required.
Good afternoon, sir.
Good afternoon.
Sir, if patient is on atenolol, as atenolol is non-cardiac selective beta blocker, so if he is taking atenolol 25, I want to shift to bisoprolol. So how to shift?
Not that atenolol is also quite beta selective for beta 1 selective. It's not as non-selective as propranolol. Depends on what indication have you started atenolol for. If the primary purpose is starting for hypertension, beta blockers are not the recommended first line of treatment for hypertension anymore. I think almost from the last two JNC updates, that is the second or the third addition of drugs is beta blockers. As far as if you want to just change from atenolol to bisoprolol, then I think you can just stop the atenolol tablet completely and switch over the patient to maybe 2.5 or 5 milligrams of bisoprolol.
Okay, thank you, sir.
Depending on what the current heart rate is. Is 25 milligrams actually controlling the heart rate, or is the patient's heart rate still 80-90 at with 25 mg of atenolol?
Yes. So bioequivalence is 25 milligram of atenolol to 2.5 milligram.
No, there is no such bioequivalence. I'm just telling you out of my experience. Okay, normally this is what I would be. To err on the safer side, I would recommend starting with 2.5 mg and then upgrading over 2 weeks. But आपके जो patient है with atenolol 25 milligrams, what is the heart rate?
She's 66. 64, 66.
So then, if it's so well controlled, why do you want to change?
Because as per newer beta blockers are much better than older beta blockers. That's why I'm thinking.
No. What is the objective? Why is the patient on atenolol?
She's taking atenolol since years. I think previous practitioner prescribed amlodipine plus atenolol combination for blood pressure.
So if everything is controlled, then I don't think unnecessarily, I personally, at least in my practice, if everything is well settled with something with the patient is taking, I normally don't tend to change something just for the sake of it, because if the patient has some heart problems, patient requires, EF is down or something like that, or the BP is not getting controlled, heart rate is not getting controlled, then I can understand, okay, we want to change. But if everything is fine, I think there is no need to change.
Okay, sir. And is any positive effect of lipid profile of bisoprolol?
Yes, I think I mentioned that that before, that it has no predilection towards like metoprolol. Yes, at times leads to increase in diabetes. So this has no effects on your lipid or your diabetic levels.
Oh, thank you, sir.
If there are no more questions, I think we can conclude the session. So I thank you, Dr. Tanay Padgaonkar, for a wonderful presentation. I also thank all the audience who have taken out time from their busy schedule and attended this knowledge sharing session. Hope to see you again in such future programs. I also would like to thank on behalf of JB Chemical each and every doctor fraternity here for their role in fight against COVID. I am sure all of you are taking care of yourself. Definitely you are sacrificing your time and efforts for the treatment and betterment of your patients. So we hope all the best and take care of yourself. Thank you,
Yeah,
doctor.
thank you so much. I think everybody needs to be a little extra careful with Corona, and please be safe and take care of you and your family.
Thank you, sir. Thank you. So with your permission, I am ending the session. Thank you.
Yeah, thank you.
Sir. Okay, sir.